incision, you need to cut the periosteum so that you can easily elevate the mucoperiosteal flap in the hard palate area. So again, very carefully to make incision in the hard palate. Now there is about small 1 or 2 millimeter cut that can be turned over for the nasal side repair. Now the same incision continue in the other side, and then gradually go anterior with certain careful. I mean the incision force not to cut too much in the membranous bone. And then with the double hook, you can easily elevate the mucoperiosteal flap. Now, if you still see some periosteum still intact, then you can use a knife like this. You can use knife just easily separate the periosteum. So basically this elevation is not difficult. I actually like to do sharp dissection. So in the whole surgical procedure, actually I do not use coagulation or electronic cutting, just the sharp dissection. And this is the blunt dissection to use the periosteal elevator. So the elevator flap. So you can, that is the junction, very thin area muscle insertion in the posterior border of the hard palate. So you need to be very careful. And then with the hook, I can identify the muscle, gently divide the muscle from the nasal mucosa. Now again, I emphasize the traction by the small double hook. And then because I do surgery, I use a magnifying loupe so I can see the muscle clear. And here again, the junction, you need to be very careful. Do not injure the mucosa. And then divide the muscle from the nasal mucosa, so the muscle will remain attached to the palatal mucosa. I do not detach the muscle too much from the nasal mucosa. Otherwise, the nasal mucosa will become very weak, fragile, difficult to hold suture later on. So just dissect much of the muscle from the nasal mucosa in this side, because the muscle here in the palatal mucosa will be rotated and then go to the middle of the soft palate. Now you see I use a double hook, then I can see that where is the structure here. Then I temporarily move to the right side and then do the same dissection. And you can see here the mucoperiosteal flap is not easy to detach. If not, you can use the number 15 braid to divide the periosteum. Then I quickly reach, after I see the transverse suture, then I can go to the posterior end of the hard palate. Then I start to dissect the muscle again. Here, I carefully dissect the muscle away from the palatal mucosa. So the muscle on the right side stay with the nasal mucosa. And again here with the double hook traction, I can easily identify which tissue or ligament is limiting the movement or the elevation of the flap. Certainly here I already identified the greater parting foramen and the neurovascular bundle. So under the traction, then I can see the limiting ligament. I use a scissor to dissect the ligament. gradually I can see the hamular process. I can identify some more ligament here is divided, and then I can identify the space of uns uh, between the superior constricted muscle and the hamular process. And then I can see the tensor palatini muscle there. Then I use my scissor to cut the root of the hamular process. And then see here, and I dissect the tissue away from the palatal mucosa. Then I come back to this side and continue the dissection. And again, I identify the pyramidal process, and then I'm checking where is the limiting ligament tissue, and I will dissect and I will detach the tissue from the pyramidal process. Until again the same, I can identify the space of uns, the hamular process, and the tensor palatini muscle. So the double hook traction is quite a useful instrument in palate repair. Then I use a scissor to cut the root of the hamular process, and I push the hamular process together with the tensor palatini muscle medially. So that will open up the space, but most of the soft tissue will be mobilized to the uh, to the medial portion. Then you can check that the flap is soft. Here also you can see the tensor palatini tissue muscle there. And again, check the looseness of the flap before the repair. And also, this is the levator muscle here. Now I dissect the mucosa from the vomer. The vomer flap is to be used for nasal side repair, and this is the right side is the greater segment, and you can see the vomer junction with the hard palate. Always some muscle fiber attached here, and very careful dissection here not to perforate the mucosa flap, so the nasal side repair can be intact with no perforation. Then I use the 4-0 Vicro for the traction, temporal traction, both sides of the mucoperiosteal flap. Again, this is the levator muscle here. This is from the posterior border of the hard palate. Then I dissect the levator muscle a little bit from the nasal mucosa, and I make incision. And again, I mentioned that this is a small Z, so it's only 5 millimeter. And then from the contralateral side, I open up the recipient side. So again, use the 4-0 Vicro, and I suture this the right side mucal muscle flap to the left side. I think the bite of tissue here is important, that you could have a good suture approximation without tear. So the muscle to muscle suture is important here, and this suture is a very important suture to keep tension and not separating. And this is to suture the other triangle. And this is mainly the mucosa suture, so it's not as secure. But again, you see here that there is minimal tension, so the flap remain intact. I think if you have a good nasal side repair, palatal side repair, then it will be have much less chance that you develop the fissura. And then I suture the muscle part in the soft palate, in the middle and posterior soft palate. And again here the suture is intended to approximate the two sides. Now people ask why you put the suture inside the tissue instead of in the nasal outside the wound in the nasal cavity. I think both is okay. It's my personal habit that I do it so many years, and I feel that this is easier to perform the suture. And this suture go gradually posteriorly to the uvula. So I usually do very careful approximation here. Actually, in the palate repair, no single suture can be mixed out. You have to be carefully perform the suture in every stitch. And I always use interrupted suture. In the palate repair, I don't use continuous suture. Now again, when I approach to the uvula, now it become more and more mucosa portion. So you need to be careful that you don't use too much tension. Otherwise, this suture may cut through the mucosa. And then you go back, you see the wound, you see the baby's mouth, you see bifid uvula. So this is suture in the mucosa area, in the uvula area should be very careful, very snugly suture the uvula. And I always very carefully approximate the uvula because many parents, grandparents will look for the uvula. They feel the uvula is important. So you can see here from inside, posterior, and then to the palatal side. This is the uvula, very gentle suture, not too tight. This is 4 micron. Then gradually go to the anterior part. And again, the nasal side mucosa suture has to be careful. Try not to create any dehiscence. Certainly, this is when you dissect, you need to keep some healthy tissue here. This is the most critical area, the junction between the hard palate and soft palate, where the most of the fissure happen in this region. So, but if you do the double opposing Z, actually this is a double protection compared to the pure two flap technique, because the Z is in the different size. So usually the protection from the dehiscence is much better, from the fissure is much better. And in this area, you always can find a mucoperiosteal flap because the periosteum is always there. So care for the dissection. Certainly, when you dissect the nasal side mucosa, you do not want to perforate to injure the nasal mucosa. Otherwise, in this area, the closure will not be possible, and you have an opening in the nasal side. But I feel that if you have unlucky to have an opening in the nasal side in the hard palate here, it's still okay because the palatal side is very secure. Then you still don't have the fissure. So so the palatal side repair is even more important. Now this is the uvula muscle suture, and I always put one suture to approximate the uvula muscle. And I feel that with this uvula muscle repair, I can have a better uvula appearance. Well, whether uvula have function in terms of speech, I don't know. There are some researchers believe that after using the some biomechanical study, bioengineering study, they feel that the uvula has some function for the speech. They say about 9%, if I remember correctly. It's by Dr. Ken Lin. But most of the opinion say that uvula actually is not related to the speech function. But the good appearance of uvula is important. It's a cosmetic purpose. So when I finish repairing the uvula, then I start to approximate the two anterior end of the fret, mucoperiosteal fret from two sides. Then I start to do the Z-plasty in the palatal side. Now this is in the left side. This should be muscle mucosa fret. This is on the right side. This is only the mucosa fret. And again, a small Z. And with the small Z, then we could repair the two sides easier without too much tension. And also with the small Z, the palatal repair is not linear, okay? So that we don't have so-called linear contraction that happened in the two fret palatoplasty, because this is a curvilinear repair. So after this Z-plasty approximation, quickly you see that the two lateral relaxing wound become open. See the two lateral relaxing, the wound become bigger than before. But still the two sides of the tissue, you can see that the tension is not big. So I can easily suture approximate the tissue together in the midline. Oh, I forget to mention that in the nasal side, I did not suture the central limb of the Z, because I feel that that can prevent shortening, and also that provides small opening for drainage of the hematoma, possibly. But in this palatal side, I will suture the central limb of the Z. Now I suture the two sides of the angle of the Z, and later on I will suture the central limb. So gradually I repair the soft palate posterior to the Z. And then I approximate the tissue here. Be very careful that look at my assistant is using the ointment to protect the lip, the median. So in this area also the tissue could be weak. If the tissue is weak, you need to bite a little bit a bigger bite in order to have a secure suture. If your dissection is not perfect, then in this suture in this area, the junction area, be very careful. Oh, this is the central limb that I put a suture just to approximate the two sides together, just further secure. So again, here I use interrupted suture with 4 velcro, and I know some surgeons use continuous suture, but just I prefer myself to use the interrupted suture. So when I go gradually to the anterior part of the half palate, actually the tissue here actually is easier and is more is safer for the closure because dehiscence is not going to happen here. The biggest tension usually is in the junction between the hard and soft palate. So in that area, you need to be careful. So I finished the midline approximation. Then I suture the flap back to the anterior part. Actually, no matter the size of the palatal cleft, I think with adequate dissection that I mentioned here, you should be able to avoid the dehiscence and fissura. And then I think this is the #1 step that you achieve adequate repair. And then you can see what happened in the future speech development. But if you have a fissura, then the speech result will be compromised, will not be ideal. And certainly in this repair, #1, I did not have tension. #2, I achieved adequate muscle reconstruction. And this muscle dissection is easier if you have muscle attached to one side of mucosa rather than so-called the pure intraverular-plasty, the muscle dissection from away from the two sides of mucosa. To me, that's more difficult and not easy at all to me. So for my practice, for my teaching, I usually would suggest to use this double opposing Z-plasty with one side of the muscle attached to the mucosa. And actually, the muscle dissection is not too extensive. So I think it's easier to learn. It's easier to have so-called intact flap without injury, without perforation. Still, you see that the flap is mobilized to the midline and suture with minimal tension. In the anterior part of the half palate, the flap can always suture back. However, in the posterior part of the half palate, as well as in the tuberosity, in the pedicle, in the pyramidal space, that still remain open, and I do not intend to approximate the wound here. Okay, you can always during your closure of the palate, you need to pay attention to the tension in the midline, especially tension in the junction area. If you see tension, please release the suture. You would release the suture from the lateral, from the lateral side across suture, because from the lateral side we can easily use a buccal fat pad to cover the lower surface area. So lower surface area is less a problem. Now I puncture the buccinator muscle. Okay, remember you puncture the right muscle, buccinator muscle here. Then you can quickly see the buccal fat pad. If you puncture the wrong side, you puncture deeper to the superior constrictor muscle, you will not get buccal fat pad. And this buccal fat pad is abundant, so you can easily obtain the buccal fat, and then I do harvest of the buccal fat pad from the other side again with the traction, puncture the buccinator muscle, and quickly you see the buccal fat coming out. So it's not difficult to harvest. I know from the some beginner from the beginning cases, you may be difficult, but then if you can identify the buccinator muscle, this buccal fat harvest is not difficult. And I believe that this fat covering of the lower surface is helpful to reduce pain. That I cannot prove, but can reduce the fibrosis, can improve the development without scarring fibrosis, and that we already have data to improve. And I use so-called retention suture, gentle retention suture, to hold the buccal fat without coming in, without going back, or without coming out. And this is important because after this operation, the baby may cry, the cheek pressure may increase, then the buccal fat may come out a large portion, that like a peanut in the mouth. Sometimes the parents will be very surprised. Dr. Lo, what is this? So I said that you don't feel afraid. It's just buccal fat. Usually buccal fat disappear in about 3 weeks. And you see here, I very carefully hold the buccal fat with the two in the wound, and do not increase the tension in the midline suture. So you just maybe take 15 minutes more to harvest the buccal fat. I used to use a Surgicel to cover the lower surface. And certainly Surgicel is a good material, but we compare the Surgicel with the buccal fat, and then we find that the buccal fat group has a much better, significantly better palatal dental arch development. So I would suggest to use the buccal fat to cover the lower surface. It is free, and fat cell is good to reduce the fibrosis as well.
Yes, Professor Lo, can you hear me?
Yes.
Yes. Okay. One of our participant asking one question is what is your opinions regarding two-stage palatoplasty?
Usually, long time ago in Chang-Gung, we used two-stage. Uh, while in our experience, we don't get better outcome with the two-stage speech and also the facial growth. Uh, so we stop two-stage because I think I can use just a single stage like this to completely close the wound and I can get a very nice speech result. I know some surgeons may do Vomer flap in the first stage with the lip repair and then come back to do the palate repair, the soft palate repair. However, you also do, the second stage, you do palate repair, you still have some fibrosis, scarring. And if you look at my palate repair like this, actually this is not difficult and also this is just the whole tissue is a fresh tissue. You can dissect easier and then to repair. So I use this for a long time. Actually, we do not have a comparison between the two approach. Now, after this repair, let me mention the post-operative care. And I feel that it is very important because like, people ask, well, why you have such a good result, your wound healing, your speech outcome. I think one reason is that we have a very nice post-operative care. And we have a nice nursing specialist, Teresa. She is doing very nice care and also not only care, but also educate parents before and after surgery, and also during the follow-up. So to have good education of the mouth care, the wound care, certain protection is quite important. Because 9 months of age, the baby is easy to follow the order to have 2 weeks of milk feeding, okay, liquid diet feeding. Usually not a difficult problem. Then oral hygiene, certainly you need to, you can have a different way of oral hygiene care. And our nurse are very strict to instruct parents to use irrigate the wound after the surgery. I think medication is pretty much similar. You pain medication, antibiotic for about 1 week, and whether you need a hand-arm restriction is up to a different center and surgeon. And we will see parents if they are good, cooperative, then the baby certainly do not need a restriction. But if you feel the parental care is not good enough, then you need to do some kind of restriction. And also the nursing specialist, I think in your group, if you can have a specially trained nursing that take care of all the cleft patients, that would be very good. And education to the parents is also very nice. Now, in this presentation, I mentioned the key point. Actually, I pretty much emphasize the tension release, very important, because I feel that many surgeons do not have adequate tension release of the flap and the pedicle. Then you try to use the suture to hold the flap together, and that is dangerous. So please do adequate tension tissue dissection, dissect the pyramidal space, release the tension. And if you do not feel tension, then you can have a good sleep in the night. Certainly, the muscle repair is emphasized by every surgeon. Every senior surgeon will teach you how to do a good muscle dissection and muscle repair. And with my technique, I think the muscle dissection is much easier, just a limited muscle dissection and 5 millimeter of incision. And you can turn the muscle from oblique to horizontal and repair each other. Lengthening, you don't need much lengthening, just a small Z is enough. A large Z, you increase tension and you lengthen the subpalate too much. You may be careful about the postoperative airway. And then lastly, the postoperative care is certainly important. Now, if you wish to see some article, these 3 article has been published and then mentioned a lot of the tension release and the modified double precision Z-plasty.
Okay, yes. Thank you, Professor Lowe. Thank you for all the participants tonight to come along with all the video presentations. I have to say sorry for all the participants. Actually, when the Professor Lowe is presenting his wonderful video, a lot of the participants give me the hint and give me a lot of message because I'm so sorry to limit the upper participant only to the 100. So next time we will expand our volume to welcome all the possible participants to come join with our party tonight. So I'm really to say sorry for all of you. So after my apologize, I have some questions from the audience to asking Professor Lowe. So
Yeah.
for the first one, one of the participants mentioned it, are there any post repercussions after the fracturing of the humulus process in such a young age?
You mean any impact or any influence for Hamulus process fracture?
Yes, yeah, post repercussions.
We actually published an article before comparing with or without Hamulus process fracture. And I think if you check my, I think maybe 20 years ago, we published a so-called the prospective study comparing 2 groups with or without Hamulus process fracture. With the fracture, with or without fracture, the result is the same. It's just the conclusion is this. In terms of the tension, you know, the speech outcome, or the ear. I mean, we actually compare the ear, the middle ear effect. We found that there's no particular difference between the 2 groups. You can see that when I dissect the pyramidal area, and I fracture the hamular process, actually the tensor palatini muscle is still intact. So in terms of the ear result is the same.
Okay, so for the next questions, following for the previous one, he asking what is your opinions of post-operative obturator for operation size protections?
Post-operative obturator.
Yeah, to protect the OP site.
Does that mean that a kind of certain appliance to put into oral?
Yes.
No, we don't use that. I think because we're doing the patient at 9 months of age, and if you strictly use the food like liquid diet, that should be safe. Okay. Yeah. So we do not use protection obturator to protect the wound.
Okay. The next question is when Professor Lo, you operate the palatoplasty, how could you measure or how could you evaluate the lengthening to prevent in the future the velopharyngeal insufficiency? What is your evaluation intraoperatively?
The length.
That maybe the lengthening, the length.
The length
yes.
of the soft palate lengthening.
Yes. Yeah.
Well, this is a good question, but I I did not measure the increase of the soft palate length after the surgery. It is a small Z 5 mm limb. Uh, uh, if you can see that if you use the Z, you actually lengthen the soft palate to a certain degree. The other important part is that this is not a linear wound. So this is a curved wound. So scar contracture will not happen. And also the soft palate patient keep eating. I think the soft palate function is actually quite nice. So I'm sorry, I didn't quantitatively document the length that I obtained from this procedure.
Okay. Okay. The next questions. So, Professor Lo, what is your opinions regarding the non-radical intravelar veloplasty?
Non-radical.
Yes.
Maybe you can say that my technique is non-radical and Dr. Sommer's technique is radical. Well, I don't know. I personally I'm not a good muscle dissection expert because if I dissect the muscle from both sides of the mucosa, then either the mucosa become very thin, difficult to suture, easy to tear, or the muscle bundle is weak, it's not as robust that I can suture together. So, but using my technique, I think it's easier to learn rather than do the radical muscle dissection. And so my muscle dissection actually is quite limited, but I feel that this is quite helpful and easy to learn.
Okay. The next questions. Is the palatoplasty is the best time? Is the 9 months? Is the age of 9 months old? Is the best timing for submucosa cleft case?
For
as well?
submucosa,
Yes.
submucous cleft palate,
Yeah, submucosa cleft palate.
or submucous cleft palate.
Yes.
No. Usually for patient with submucous cleft palate, we try to observe the patient. If the patient has speech problem, or if patient have a swallowing problem, or if patient have ear function problem, middle ear effusion. But mainly the most important observation is the speech function. So we usually, this for submucous cleft palate, I think the majority patient with submucous cleft palate, they can be they can speak well without surgery. So unless there is early sign of speech dysfunction, usually in Chang-Gung, we start to have a speech evaluation at 2.5 years. But I will send my patient to our speech pathologist, Claudia or Ruby, earlier than that, earlier than 2 years of age. That if they can listen and then they can hear some speech problem, then we can do this double opposite Z-plasty for the submucous cleft palate. So I don't do at 9 months of age. I usually observe and I do it later when there are any sign of the speech dysfunction.
Okay.
Thank you, Professor. Yes.
Okay. So the next questions. Do you use the Z-plasty for the even wider the cleft palate cases?
Yes. Yes. Well, actually, in Chang-Gung, we always repair the crab palate 9 months of age, but I also do a lot of mission, and the baby's age could be older. I still do two fret, the small Z. Even the crab width is very wide. So as I said, that if you can do adequate dissection in the pyramidal space, and you can significantly release the flat tension and suture in the midline. Of course, the lateral relaxing incision, you can open a big opening space, but you can harvest the buccal fat to cover the raw surface. So I still believe that if you have adequate dissection, you still can achieve such palate repair even in the wider crab palate.
Okay. For the next questions. Okay, I think we have two more. Okay. Next question is for the pedicle. For the pedicle mobilization, do you use the osteotomy to mobilize the pedicle?
No, in my practice area, when Dr. Nordhoff teach me also, we for especially for the older patient, we open the posterior part of the half palate posterior to the greater palatal foramen in order to further release the pedicle. We even use periosteal scoring along the pedicle to free skeletonize the pedicle in order to release the tension. But now we stop doing that. We no longer do osteotomy. We no longer do periosteal scoring to release tension, because I think to do osteotomy is further trauma. If I do periosteal scoring, I increase more bleeding. So I actually can do the technique that I described, and then I can release the tension. But if you have trouble, you still should do further tension release by doing osteotomy. I think you can go ahead, but that will certainly you need to be careful by doing that.
Okay. Okay. For the next one, questions that after the palatal-plasty, how are you evaluating the audio function in the audio outcome?
Audio outcome.
Audiological outcome. Yes.
Usually, I refer the case to the ENT. Well, I because we know that the middle ear effusion happen more frequently when patient is between 1 to 3 years of age. So I repair the palate 9 months of age. I I always tell my parents that I do not aggressively assign you to see ENT doctor, and I do not aggressively put grommet tube during the palate repair. I did that long time ago. I stopped doing that because there are more and more evidence show that if you can do adequate repair, adequate dissection, reconstruction, your middle ear function actually is better than before, than compared to my previous technique. So I stopped doing aggressive the grommet tube insertion. But I tell my parents very carefully that if you have respiratory infection, URI, you can see ENT doctor. They can check your middle ear at the same time and give medication if you have middle ear effusion. If your effusion is difficult to treat, that take a long time, for example, more than 6 weeks, is still middle ear effusion, then I think the ENT doctor will suggest that you put a grommet tube and then keep following in the ENT doctor. But right now in my hand, my patient who require middle ear, the grommet tube insertion is actually less than 10%, not many. So I think this is the protocol difference between my current protocol and also the protocol my 20 years ago is different now.
Okay, the final questions. Do you use the Vomer flap?
Vomer flap, you mean during the palate repair?
Yes.
During the palate repair, yes, I use the Vomer flap, especially for Vol 3 and Vol 4. I need a Vomer flap to repair the nasal side. Okay, but in the primary lip repair, I don't do Vomer flap repair to the half palate. I use Vomer flap in the palatoplasty, not in the lip repair. Yes, I routinely use Vomer flap in UCLP or BCLP, and I consider that is quite important for the adequate closure in the nasal side.
Okay. So yeah, I think the every questions already be answered. Well done by Professor Lo tonight. And,
Dr. Zhou, can I ask you a question?
yes, please.
In your palate repair, when you perform palate repair, what is the most difficult part that you think?
Actually, I have few experience, but the technique all I learned is from Professor Lo. I think is to dissect for the pyramidal space to identify the humulus, the bone, and to fracture the humulus. And I think if you cannot well done to release all the tension surrounding to the pedicle, it's very difficult to approximate the bilateral soft tissue. So that could be have a lot of attention once you want to do the repair. So for me, I think the well done release for all the tension surrounding the pedicle is very important to me, and too easy for the flap approximation. Yes.
Thank you.
Thank you. Okay, so I think I have to conclude tonight's webinar. I have to say sorry for again, so for some missing participant, but no problem. I already record this wonderful talk, and I will release the records in our Facebook later. So you can talk to your friend to come join our video later on. So thank you for Professor Lo's speech, and thank you for all the participants, no matter where you are from Europe, from America, you can shake in your hand for your friend in this Zoom. 2 weeks later, yeah, 2 weeks later, we have another topic. That topic will be focused on the facial trauma, and Professor Han-Chong Liao will give us a talk how to manage the condyle head fracture. So I will release the news on our Facebook. So please looking forward to this great topic as well. Thank you, Professor Lo, again, and thank you all the friends in the screen. Have a good night and have a good day. See you. Bye-bye.
Bye-bye.
Bye.
Bye.
Bye.